Hi, good morning, everyone. It's a pleasure to be here. I feel so privileged to be here on the traditional territories of the Haudenosaunee and Anishinaabe nations, and privileged to be part of this panel today. I'm going to introduce, we have 4 panelists who will be speaking this morning, so I'm really looking forward to these presentations as we talk about society and health systems under the strain of COVID. And what I will be doing is I'll introduce each speaker just before they speak and ask people to come up to join us as well. So, first, we have Dr. Doug Oliver, who's a family physician and associate professor in the Department of Family Medicine at McMaster University. He's the medical director of the McMaster Family Practice in Hamilton, where his teaching and clinical interests are in the area of the care of the elderly, palliative care, and primary care mental health. In addition to his outpatient practice, he does home visits for homebound elderly patients and works in multiple congregate settings in Hamilton. Dr. Oliver was co-lead of the innovative multi-site clinical program called Health Tapestry, which aimed at helping older adults stay independent and fit in their own homes. I didn't introduce myself. My name's Rebecca Ganann. I'm an assistant professor in the School of Nursing at McMaster University. I'm co-director of the Aging Community and Health Research Unit, and I also have the privilege of co-leading a study called Embolden, which we co-designed with older adults and communities, a mobility promoting intervention to promote health and independence for older adults living in the community. But back to you. Dr. Oliver, please.
Thank you so much for that, Rebecca. I don't have anyone else to introduce, thankfully, so I'll just stick to my own script. Thank you so much for the invitation. I spoke to Parminder a few weeks ago, and he asked how I was doing, and we hadn't talked in a long time, and I told him I was experiencing quite a degree of burnout with the work that I've been doing clinically for the last 2 years. And he invited me to come today, and I thought this was a support group meeting. So imagine how I'm feeling right now. But I do get to talk about a topic for the next 10 minutes that is very near and dear to my heart. And this is a topic, I'm going to make an argument and a case in the next few minutes that needs a heck of a lot more light shone on it. Mental illness in older adults that are living in congregate settings has long been a topic in an area of healthcare delivery that has lived in the shadows. If I can shine one little bit of light on it for one of you today, this has been worth my trip. So why do we need to shine light on it? We're in a crisis phase now like I've never seen in my 20 years of practicing in these settings. As I look at the title of this this talk, it's uncharacteristically gloomy for me. I'm actually a pretty optimistic individual when it comes to delivering healthcare to older adults. I always believe that there is a way and something that we can advocate for. But I will just start by saying that it's a crisis time right now for individuals with mental illness. Especially older adults, especially in congregate settings like I've never seen before. And it's the first time in my career I've actually experienced a little bit of fear that we don't have enough team members and enough innovative spirit and minds that are putting their heads together on this problem. So I am extremely grateful to be here today and very grateful that this is even happening. I don't have any conflicts to disclose. I want to start off with one tiny little pet peeve of mine. When we talk about people living in congregate settings, they're not all built the same way. They're not all resourced the same way. And this is just one small example of some of the differences between long-term care and retirement home. I happen to work in both of these settings, and there are a lot of people struggling in both of these settings. Retirement homes in particular are notoriously underreported on how badly staffed they are. So we're talking one nurse usually for 100 patients, just Monday to Friday, 9 to 5. So that's the retirement home level of care right now. When I started my practice 20 years ago, people living in retirement home today were living in long-term care homes back then, for sure. And that evolution has happened in the last 10 years. These are extremely fascinating, amazing people with amazing stories that have a lot of complex and heavy needs, and they're really going neglected at this point. So the perfect storm happened in the spring, summer, and fall of 2020. I don't need to rehash it for you. You all lived through it. But it was a perfect storm for some of these settings because at baseline, long-term care homes and retirement homes are understaffed. They have been for years. There was minimal, if any, PPE available. infection prevention and control practices were not well rehearsed or even known. At the time, of course, there were no effective therapeutics available to help stem the tide once the virus got into these congregate settings. It's a highly transmissible virus, as you know. Up front, there were massive delays in testing, so oftentimes we didn't know what we were walking into. So everybody had to fully don and doff full PPE for every patient encounter. It was exhausting for healthcare providers. My nursing colleagues, personal support workers bore the brunt of that burden. And of course, as I mentioned, we've got the most vulnerable individuals living in these settings already. It was truly the perfect storm. We all know the price that was paid as a result of the virus, but I'm here to talk to you today about the price that may be paid now and in the future on the mental health front if we don't learn something from what's happened over these last couple of years. I also want to make sure that everybody understands I'm not making an argument against the protection measures that were put in place. Every single public health measure that happened was done to help save lives, and they saved tens of thousands of lives. Restricting visitors, I hate to say it, it saved lives. Masking, gowning, gloving, cleaning, all of the social distancing measures, they all saved lives, and they all bore a consequence as well. And some of these pictures are going to share a little bit about what the consequence was. So the virus itself led to higher death rates in congregate settings than any of us have ever seen. That has been well publicized. We just didn't have the protective measures in place or the understanding about this virus to be able to stop death from happening. And it did happen at really high rates. 80% of the deaths across the country happen in congregate settings to older adults. The impact on staff of these facilities, we are going to feel the impact of this for years. There is no quick fix. We have homes that cannot staff right now with enough nurses or personal support workers to provide basic care for people. And the impact on every aspect of an individual's care is being felt immensely every day. I'm talking about mental health, but the impact that mental health has on mobility and fall risk, quality of life, go down the chain. How we're going to get these workers back is a topic for a whole other discussion, and I hope there's a whole day planned on it. And I hope there's a lot of brains at the ministry level and organizations like MIRA thinking about that. I'm sure there's an economic answer and some equation that's going to do it, but right now, nursing homes are competing with Tim Hortons for PSWs, okay? And Tim Hortons offer benefits, and the pay is a little bit higher. So until something dramatic happens to try and honor and respect the work that PSWs and nurses have to do in these settings and how well they can do it when they're resourced properly, nothing's going to change. This may be the saddest picture that I have to share with you today. Visiting restrictions were real. They had an impact. Even though things have opened up now, there is still an impact. There are family members that are still not feeling comfortable coming back into these homes to visit their loved ones, and that's a big deal. Now, at the start of the pandemic, unfortunately, I had a front row seat to, for the first time in my career, having people that were forced to die alone because of the visiting restrictions. This last photo is meant to represent what's happening now. People are dying of loneliness. Mainstream media was quick to pick up on this, as everybody was, but nobody had an answer. The New York Times in October of 2020 commented on the slow killer nursing home residents were withering in isolation. The Forbes magazine the same month picked up on the fact that COVID-19 is driving an epidemic of loneliness in nursing homes. So I'm going to talk for the next 2 slides about the mental health diagnoses that we see here. This is the fire. This is the fire that's raging all the time. Loneliness is the gasoline that's getting poured on the fire right now in social isolation. It's the gasoline, okay? So over 20% of residents in long-term care, this is pre-pandemic numbers. We're suffering with full clinical depression, living in congregate settings. An additional 30% were believed to have significant enough symptoms of depression to have an impact on their mobility and fall risk and overall quality of life. Approximately 50% of that number is actually low. It's in Hamilton anyway, 60 to 70% of people are in one of our 29 nursing homes because they have dementia or some degree of cognitive impairment. And then anxiety disorders, these are high numbers compared to the population at large as well. And these are the three key areas that we need to focus on: depression, dementia, anxiety. This is the mental health epidemic that's happening. So this is a slide just talking a little bit about isolation. Now, even at baseline, there's a lot of factors that contribute to the feeling of isolation and the feelings of loneliness that older adults experience. And we've just added COVID-19 onto this already pretty big pile. Living alone, chronic illness, hearing impairment, loss of loved ones, lack of exercise, all of those contribute to loneliness. And what does loneliness contribute to? It contributes to poor outcomes. So the potential impacts of loneliness and social isolation: increased risk of premature death, dementia, heart disease, stroke, higher rates of depression and suicide, and a reduced quality of life. And one of the biggest challenges for folks living in these settings is finding some meaning in their life. Every day for months and now years has felt the same because a lot of the programs that were there before have not come back. We've got to figure out innovative ways to bring them back and keep everybody safe and make them better. Because if we keep doing the same things we were doing pre-pandemic, we're still not going to be where we need to be. So the last two slides. To summarize the current landscape, long-term care and retirement home residents are suffering from anxiety, depression, and dementia in really record numbers right now, and a lot of contribution has come from COVID-19 and the restrictions that came with it. There are currently minimal, formal, structured, funded resources available to help older adults with mental health specifically, and that needs to change in Ontario. As mental health needs continue to be neglected, I've already mentioned activity levels decline, fall risk increases, quality of life goes down. And the staffing crisis is the worst in this province's history. Now, I promised I was going to leave with some hopeful bit of information. I'm getting depressed just hearing this talk so far. So the last slide's going to be on some of the things that we can do and why it's important that we make the effort. So early identification matters, everybody. Like, these people are living and suffering in silence in a lot of these homes right now. We need to be able to teach staff members to identify, teach family members to identify, clinicians that are on the ground to identify individuals early who are suffering with depression, anxiety, or cognitive impairment. That will lead to early access to care if we can come up with more innovative programs to provide it. We have to build capacity through education, and I don't just mean what it says on this slide, the education of family members and people already working in these homes. We have to start with some educational planning and a generational shift in the way we teach and train medical students and nursing students and social workers and OTs and PTs across the board. We need to make work in congregate settings feel appealing. Where's the carrot for these people to want to work here? They're competing for jobs with all the sexy professions in Emerge and OB. That's where all the grads want to go. This work can be rewarding. We do a terrible job of selling it to people. And I hope that will change. Finally, innovative behavioral activation strategies, group counseling, and digital mental health tools, they are all out there, and we need to bring them back. They're designed to assist older adults and their families. Thank you so much, everybody, for your time and attention. I'll look forward to the panel discussion and to hearing from my fellow speakers.
Thank you. Thanks very much, Doug. We have some great innovative thinkers in this room, but I think what I'm taking away is even thinking about how we move forward from what we've learned and ensuring that there's actually action on it. It's my pleasure to welcome Dr. Arthur Sweetman to the stage. He's a professor in the Department of Economics at McMaster University, where he holds the Ontario Research Chair in Health Human Resources. He's also a member of McMaster's Centre for Health Economics and Policy Analysis, or CHEPA, and his research is primarily at the intersection of health economics and labor markets, so welcome.
Thank you very much. So my talk, a lot of it is looking forward. We're going to look backwards a little bit, but we're going to spend quite a bit of time looking forward. I hope I'm not too loud for you. I'll back up a bit. So I'm going to start off. I think Doug said he was depressing at the beginning, and then you have an economist next, so just wait. So the fiscal background in Ontario is not good right now. Right, Ontario, this is the context that we're growing out of COVID in. Ontario's net debt to GDP ratio is the second highest in Canada. So among provinces, we're not doing well. Only Newfoundland is in worse shape than us. The 2021 budget said that the debt's going to increase for most of the remainder of the decade, and that they expect inflation-adjusted per capita program spending to decline by 12%. And that was the old inflation-adjusted, not the new inflation-adjusted. Healthcare is supposed to be protected, which means that it only declines by 8%, as opposed to everything else declining by 12%. That's what we're growing out of, right? But having said that, affordable in healthcare, or what's affordable for healthcare, is about priorities, and it's about context. And Canadians are a little bit of two minds. So Canadians, whenever they're patients, they want more services. And Canadians, whenever they're taxpayers, they want fewer or stable costs. And Canadians change hats regularly. And if you've ever read Fessinger's theory of cognitive dissonance, it doesn't seem to apply, right? Canadians don't realize that they're being logically inconsistent. And everyone always wants the good two-for, which is more efficiency, which means they want both more services and lower costs. And we all know that that's not real. So I want to talk about three things today with this big background in terms of what's happening. And first, I'm going to think about the way we measure what happens in the workforce matters. And I'm going to show you a way of thinking. I'm going to use physicians as an example here, but I'm going to give you a way that the ministry doesn't think about measuring physicians. So this is one way they do think about it. This is advanced from the ministry. Usually there's focus on number of physicians. So the big innovation here is that it's number per population, number per capita, per 100,000. And you can see that in 1987, everyone thought we had a surplus of physicians, right? And then there was a big reduction in the number of seats in medical school. In fact, we didn't actually reduce things very much because we had other avenues. And then we started increasing in 2005. It took a long time for people to realize that we need to increase the physician supply. But this is what the ministry was looking at. However, physicians over that time, as we all know, were reducing their labor supply, and in recent years have reduced labor supply quite dramatically. So this next plot simply adjusts and says if we take 1987 in all cases as a base year, and we say what happens if we don't look at headcount, but we look at physicians' labor supply, number of hours, or full-time equivalent physicians. And you can see that changes the picture quite a lot. What if let's go back to looking at bodies, but let's imagine that we don't look at the population as if the population stays frozen. We say that the population is getting older. And we know that people who are older take more hours of physician labor supply on average, compared to people who are younger, except for very young, of course, that's a different story. So if we age adjust the population, you can see that our per capita numbers again drop quite a bit. If we combine the two, that is to say, if we combine the reduction in labor supply by physicians and the increased needs of the population because of population aging, you can see that there's been a very dramatic drop in physician labor supply that really has only come back to its early 1990s level in the last year or two. Right? And of course, physician labor supply dropped dramatically at the beginning of COVID in 2020. And this is just because as much as some people were working really hard during COVID, on average, physicians' hours went down during COVID, especially in the first year of COVID. Okay, so what's the story here? What's the moral of the story? As we think about workforce planning, we need to be thinking about the worker side practice changes and effective supply, not just headcount. And I can tell you that the ministry focuses on headcount, and they don't adjust for aging of the population. They sometimes adjust for hours, but in fact, they don't have hours for the most part. I should also say that I suspect my green line, my bottom line, which is the most negative line, is actually optimistic, because I think physicians are spending less or fewer hours in direct patient care. And the only numbers I have are numbers for total labor supply for physicians, not direct patient care. So I actually think my green line is optimistic. Right? And so that's an amazing story, because we have increased labor supply, we've increased the head count of physicians dramatically, and I think that we're really only back to where we were 20 years ago in terms of actual direct patient care. And again, so population aging is a really important component of thinking of labor supply that I don't think, everyone talks about it, I don't think it's actually operationalized in terms of ministry planning. Topic number 2, PSWs and long-term care homes. So I'm going to give you some projections about what we need to think about in the near future in terms of this workforce, this important element of the workforce in long-term care. And I'm going to do 2 things. First, I'm going to do a simple steady as she goes projections for all of Canada. And then I'm going to focus on Ontario, and I'm going to think about the difference for Ontario because of the recent announcements by the Ontario government. So if we look in the last 15 years or so at the PSW labor supply in all of Canada, we can see that the blue lines are actual measures of bodies of people. And we have an average annual growth rate of around 2.5%, which matches almost perfectly the average annual growth rate of the population over age 75. So really what we've been in for the last little while, in some sense, is a steady as she goes approach. That is to say, our PSW labor supply or our PSW workforce has been increasing almost at exactly the same rate as the over 75 population has been. If we think that that kind of projection is going to continue, if we think that that rate of growth is going to continue, we all know that the baby boomers, the leading edge of the baby boomer turns 75 in 2021. So that means that we're going to need a lot more PSWs in the near future. So these graphs tell us how many new PSWs we need each and every year for the next 40 years or so. And you can see between 2020 and 2040, we need, for Canada as a whole, assuming the steady as she goes approach, we need roughly 10,000 new PSWs each and every year. That's an amazing number of people if you start thinking about that. However, the Ontario budget in 2021 made a bunch of announcements about long-term care homes. And what Ontario is saying is, we don't want steady as she goes. We want something more than steady as she goes. So we have to think about not just the 10,000, but what do we need on top of that? So there's 3 things that Ontario said that are relevant to us. First, they said they were going to increase average direct daily care for long-term care residents from 2.75 to 4 hours. And I actually made a mistake writing this. And you guys all know about long-term care homes, so you probably caught the mistake right away. The 2.75 hours is actually not direct patient care. That's paid care. The 4 hours in the promise was actually direct patient care. So what's the difference? So let's imagine that in the future we start doing more IPAC training. So IPAC training counts for paid care, but doesn't count for direct patient care, right? So going from 2.75 hours of paid care to 4 hours of direct patient care is a much bigger than a 1.25 increase in hours, right? We also promised 30,000 new beds by 2028, and the government committed $121 million to accelerate training of nearly 9,000 new PSWs, okay? 121 million sounds like a lot, just wait. Okay, so here's what we've done in Ontario for the last 20 or so years in terms of long-term care. So the actual line is the solid bottom one. I'm going to try using the spotter here. The solid bottom is actual from 2003 to the present. So what we've done for the last 20 years is basically zero. When Dalton McGuinty was premier, there were 78,000 long-term care beds in Ontario, and today there are roughly 78,000 long-term care beds in Ontario. There was a very clear, deliberate policy decision to not expand long-term care. There was a sense we had too much, and to put money into home care. Like many things that we do as a society, we were really good at shutting down the increase, not so good at increasing home care. Right, so if we had frozen the beds per capita or beds per person over age 75 at its 2003 level, then we would be on this shaded line here. So if we had today what we had at the same ratio as we had in 2003, there'd be around 30,000 more long-term care beds in Ontario. Now, I'm not saying that that's having fewer is good or bad. Having fewer without additional home care is probably bad. But at the moment, we're like 30,000 below where we would have been 30 years ago. That has very substantial implications, as you all know, for acuity and long-term care. The government's big expansion is this, I don't know if I can make the pointer work, is this dark line here. The expansion is basically, the expansion is the dotted line. This is what the government projects it's going to do. And if we compare that to freezing long-term care per person over age 75 at 2018 rates, the expansion almost, but not quite, keeps things as good as they were in 2018. So the expansion, in some sense, is really a steady as she goes, but it's the steady as she goes keeping things frozen as they were in 2018 almost. Not quite that good, but almost. So the big expansion is not really an expansion, it's just a recognition that the population is growing and aging. That's all it is. It's not making more beds per capita, it's just not having fewer beds per capita. Okay, so what's this imply? What is this, these two policy changes, the more hours per person, and the more beds, what does that mean for how many PSWs we need? And then there's similar things I don't have time to show you for nurses, et cetera, et cetera. So the 121 million was supposed to accelerate the training for 9,000 PSWs. Now let's be crazy and assume that everything works perfectly. We all know that that doesn't happen. So assuming that every single PSW trainee successfully completes and stays working, or alternatively, if a PSW leaves, we get someone from out of province. And let's imagine that all 9,000 count towards the new expansion. So none of them do sort of the regular replacement. So the 9,000 we'll assume is above and beyond what we always used to do. You can judge for yourself if these are reasonable assumptions or not. Then the government needs to repeat the 121 million about 6 more times by 2028. So I think they believe that this was a one-time and we're going to spend a lot of money and we're going to fix it. This is not a one-time. We need to do this almost every single year for the next decade just to keep pace with what we say we're going to do. Okay? So there are big ramifications from the changes. The changes Ontario proposes are on the same order as the steady as she goes for all of Canada. So there are very large human resource workforce issues associated with the announced changes that I don't think have been fully appreciated. I feel now there's more. I feel like I'm doing one of those late night infomercials. Wait, there's more. All right? Starting training is only starting training. The 9,000 that the government spent the 121 million on, that's for people starting training. Informal evidence, I don't know of any really good recent studies on this, but informal evidence suggests that you need 2 PSWs to enter training to have 1 PSW working 3 years later. So training lasts a year, and then a lot of people quit in the first year or 2. So that means that my previous estimates are short by half if you want to focus on how many people need to start training. Right? These are very substantial. Now, there's a lot of uncertainty with this type of thing. It's entirely possible that retention may improve because of or as PSW staffing rates increase. So if you go from 2.75 hours of paid care to 4 hours of direct patient care, the job quality could increase, retention could increase, right? So there's a lot of uncertainty around some of these numbers. You got to take that into account. But the key issue is we face a lot of challenges, and I don't think we've thought about this as a society very carefully yet. Topic number 3, working conditions in long-term care homes. So we've heard a lot of media stories, and Doug talked about just a second ago about PSWs competing with Tim Hortons, and there's some truth to that. But are those stories outliers or are they systemic? And if we start thinking about PSWs and long-term care, we also need to think that the long-term care workforce doesn't sit in isolation relative to the rest of the workforce in healthcare or the rest of the labor market. We need to understand the context. And Doug brought up the context. Tim Hortons is the competitor, and that actually is true. Tim Hortons is the competitor. Less so for PSWs than most would think, though. I'll show you some numbers in a second. So I'm going to show you just a very small sampling of a few statistics that may interest you, just to give some context here. So these are some wage comparisons. So these are self-reported wages by PSWs to Statistics Canada. So I take them reasonably seriously. I'm showing you all the provinces, but I don't really care. Let's focus on Ontario. So in residential care is a little bit larger than long-term care. It includes, for example, retirement homes. The average PSW is earning around $22.50 an hour. This is in 2019, is when the data is from, but I inflation adjusted it to 2022 because I think most people have a lot of trouble thinking about 2019 dollars, even though it's only a few years ago. People think about today's dollars. So inflation adjusted, so they are about $22.47. If in hospitals, PSWs earn around $25 an hour. In home care, it's just under $20 an hour. In the rest of healthcare, it's just over $20 an hour. So long-term care is not an outlier compared to the rest of healthcare. In fact, it's almost as good as hospitals. And most, we're going to see it in a minute. I'll wait for a minute. Let's compare PSWs to people with PSW level education, not outside of healthcare. And then we can see that in the bottom. So for men with PSW education outside of healthcare are earning around $25 an hour. Women outside of healthcare with that level of education are earning $20 an hour. There's a little bit of a slip here because my education measures only say community college. It doesn't say 3-year program, 1-year program. And most of the men, on average, tend to have the 3-year plumbing, electricity, et cetera, program. So it's close to an apples-to-apples comparison, but it's not a perfect apples-to-apples comparison. But again, PSWs, if you're going to compare, PSWs are 90% women. If you compare the 2250 to the 2010, it's not terrible. Now, there's also working condition issues, et cetera. Now, and this is the median. I did look at like the 20th percentile, trying to find those minimum wage PSWs. If they exist, they're way off in the tail. I'm sure that some do exist, but it's not a high percentage of PSWs. The other thing, of course, you can just look at job characteristics. So I'm looking at PSWs working in, this is for their main job, because obviously there's multiple job holders. This is for their main job. How many are part-time in their main job working in residential care? It's around 20%. In healthcare outside of residential care, it's around 30%. In the rest of society outside of healthcare, it's around 20%. PSWs and long-term care don't look very different on that dimension. What about unionization? About 72% of PSWs report being unionized. And I've read most of the union collective agreements in Ontario, and most of them do have benefits, at least for the full-time workers. Part-time workers, actually, it's kind of odd. Part-time workers under most collective agreements get pay in lieu of benefits. So there's actually some PSWs out there who prefer to have 2 part-time jobs because then you get the pay in lieu of benefits. And if your partner has benefits, you might prefer 15% pay instead of benefits that are redundant within your household. So it's quite tricky, some of this stuff. When we start digging, it's not as straightforward as we sometimes would like it to be. Anyway, there's a highly unionized sector. We know exactly how much people are paid because at least many of them, we can go read the collective agreements. Right? It's not hard to figure out. Outside of long-term care, but inside healthcare, around 55% of PSWs are unionized. And if we look at people who have the same level of education who don't work in healthcare, it's only around 20%. And if we look at the number who are permanent as opposed to temporary or casual employees, we can see it's around just over 90% in long-term care, about 90% in the rest of healthcare, and around 90% in the rest of society outside of healthcare, right? So the story you hear in the media, I'm sure it's true, but it's not the median person, right? And it's not even the 20th percentile. I have those numbers too. It's way off in the tail. And then I think this is my final slide, or almost final slide of numbers, looking at RNs and RPNs. Now, I'm sorry that the numbers are a bit small. For RNs, you can see a small percentage. Oh, this is comparing across sectors within healthcare in Ontario. So how does long-term care compare to, for example, hospitals, primary care, home care, the rest of healthcare in Ontario? And this comes from the regulatory college data. So this is this is really solid data. This is a census. This is not a sample. So about 7% of RNs work in long-term care, around 27% of RPNs work in long-term care, around 5% of RNs work in home care, around 3% of RPNs work in home care. How many of the people report holding one job? Among RNs, it's 81% in long-term care. Among RPNs, it's 79%. It's not dramatically different than the rest of healthcare in Ontario for either of these, right? Long-term care does not look very different than the rest of healthcare. And what about whether your job is full-time or not? If you look at single job holders, around 70% of the people who have one job, it's full-time. It's not dramatically different than the rest of healthcare, except for primary care, where it's much lower. Primary care has a disproportionate number of people who work part-time, of RNs who work part-time. What about employment status for those with 2 or more jobs? So is the first job full-time? And around half of the people who have 2 or more jobs, their first job is full-time in long-term care. And again, it's not dramatically different than the rest of healthcare, right? So the moral of the story, residential care does not look like an outlier for what I'm going to call regular operations. Right? During COVID, there was no backup, there was no resiliency, but similar issues occurred in the rest of healthcare. They weren't dealing with the same frail population that long-term care was. So the older adult care population is going to expand tremendously in the next 2 decades. We're going to see a lot of growth until 2040, and then the rate of growth is going to slow down a lot. There's some differences across provinces. I didn't show you provincial breakdowns, but they exist. The workforce is going to need to grow accordingly, and I don't think we've adjusted ourselves to the tremendous workforce issues that exist in elder care, not just long-term care, but elder care more broadly. There are tremendous workforce issues, and I don't think we've really started thinking seriously about them. This is going to be a real challenge because COVID-19 has left public finances in a mess. That's a technical term I use sometimes, right? So we need to move wisely. We need evidence-informed discussions. We don't need one view being imposed. We need lots of stakeholders agreeing on how we move forward. And I don't think that we have that evidence at the moment. I think we're only starting to collect it. That's it. Thank you very much.
Thank you very much, Arthur. Some clear global issues in terms of health human resources, maybe not unique to long-term care, but really pressing challenges throughout the health system. So thank you for that. So now it's my pleasure to introduce to you Dr. Lauren Griffith. She's an associate professor in the Department of Health Research, Methods, Evidence, and Impact at McMaster University. She holds the McLaughlin Foundation Professorship in Population and Public Health, and she's a co-PI of the Canadian Longitudinal Study on Aging and the lead of the Hamilton Data Collection Site. And I'm privileged to work with her. And her research interests include physical functioning, frailty, and aging, as well as the harmonization of longitudinal data. Lauren, please.
Just make sure I know how to use this. I didn't realize when I made my talk that I was going to have the feel-good talk of our panel, talking about COVID-19 impacts on community living older adults. But I think one of the things that is important in this talk is thinking about this evidence base to help inform moving forward. And I think studies like the CLSA are going to be extremely important in that regard. So I'm going to talk about the CLSA, talk a little bit about it as just a brief introduction of what it is. I'm going to talk about the COVID studies that were embedded in the CLSA, and primarily a survey study. And then I'm going to just hit on some of the findings that we found that I think are important. And these are findings from our entire research group, and Marla presented some today. But I think they're really important things in terms of understanding COVID. So I'm going to be looking at symptoms, mental health, and frailty. So just in terms of the CLSA as a research platform, we call it a research platform because it really is, we collect the data, but it's available to all researchers that want to study health and aging. There's over 50,000 people that were recruited at baseline. They were 45 to 85 when they were recruited. And then about 40% of them were a random sample from the 10 provinces in Canada, and they provide data through telephone interviewing. And about 60% are from more geographically restricted areas around 11 data collection sites across Canada. And they provide their data, very similar questionnaire data, in-person interviews, but they also come to one of the data collection sites like the one here at MIP, and they provide clinical measures as well as conduct physical tests. They provide blood and urine. And here you can see we started recruitment in 2010 to 2015, but every 3 years we start a new wave of data collection. And of course, in the middle of follow-up 2 is when COVID happened. And one of the things about CLSA that actually helped us in terms of COVID and adjusting is that there was a really robust IT infrastructure, and there was a lot of accommodation strategies already in place. So we were able, I think, within 2 weeks to start collecting data again. But the other thing was this opportunity to actually understand the importance of having these population-based data and this pre-existing cohort in terms of understanding COVID. And so we launched a COVID survey study. This gives you an idea of what the actual study looked like. But I think, as Parminder mentioned yesterday, within a month of COVID happening, we were launching our survey study. So we had 2 longer interviews. We had a baseline interview where we collected kind of socio-demographic, some socio-demographic information on symptoms and COVID status, but a number of other things like social variables, lifestyle variables, population, the public health impacts, and as well looking at healthcare access and things like that. And then there was the weekly, bi-weekly surveys. Those were mostly just kind of looking at symptoms and outcomes along the way. And then we had another similar exit interview where we had a number of things that were from the baseline, but we also introduced some things like loneliness and symptom persistence, things that we kind of learned that were important along the way. And that happened at kind of end of September to the end of December in 2020. So the first study I'm going to talk about is COVID symptoms, and why is it important to look at COVID symptoms in terms of a population-based study. And one of the things we could do here is we know a lot about the symptoms people were presenting with when they had COVID, but we don't really know necessarily what the background rates were, what we would expect in the community if we didn't have COVID. So we were able to look at that. And we were also able to look at persistent symptoms. So we were able, for the people that had COVID, we were able to look to see what were their persistent, or how often they had persistent symptoms, what they were, and as well, what were the pre-pandemic factors that were associated with symptom persistence. So the pre-pandemic factors were from a follow-up 1 for me, and then the symptoms were from the COVID exit survey. Oops, sorry, back. So here, it's a bit of a busy slide, but I think it really shows you in the community. So to the right side are the symptoms that we saw in people that reported having COVID. The left were the burden of symptoms in people that did not have COVID, these symptoms that were related to COVID. And clearly you could see the dark part of these lines are people that had reported either severe or moderate symptoms. And so clearly there was a lot more symptoms reported in our COVID group and a lot more in terms of the moderate and severe. But one thing about having CLSA is we have a very large sample size too. So we can dig down a little bit deeper and look at what those symptoms looked like by age. And here you could see, I think we keep hearing things about the age effect in COVID. It was, in terms of the people getting it, it was more common in the younger age groups. But here you can see the symptoms were actually, the burden was higher in the younger age groups, but in the older age groups, you could see that there was more times moderate or severe symptoms. So we can start understanding this a little bit better. And in terms of persistent symptoms, it's actually interesting. In our community-based survey, we found similar prevalence of persistent symptoms as we were seeing in the hospitals at the time. So people that had less severe cases were still having these persistent symptoms. And so it was about 2/3 of the people had symptoms at 1 year, more than 1 month, and about half the people reported having the symptoms more than 3 months later. And again, it's a bit of a busy slide, but for both 1 month and 3 months, we had the female sex was related to, so the females tended to have a higher risk of having persistent symptoms than males, both at 1 month and 3 months. And as well, having more chronic conditions was associated with higher likelihood of having persistent symptoms. But when we looked at the 3-month time, having persistent symptoms for more than 3 months, it was also the subjective social status that came in. And it's kind of an interesting measure. This is one where you picture a ladder. People are asked to picture a ladder that have 10 rungs. That is really representing the social standing in a committee, in your community. And the 10th rung is like the highest social standing. The first rung is the lowest. So we asked people to put themselves, which rung are you on? And what we found that an increase of 1 rung was actually associated with about a 15% decrease in the risk of reporting persistent symptoms at 3 months. So again, having this rich contextual data outside of COVID actually helps us to understand some of these things better. And so in terms of mental health, we looked at depression, that was led by Dr. Reyna, and loneliness, which was led by Dr. Kirkland from Dalhousie. And here, again, we were able to actually look at trajectories because for depression, we had data from baseline to follow-up 1, and then COVID, the first COVID interview, and then COVID exit. And for loneliness, it was introduced a little bit later, so we had the follow-up 1 and the COVID exit. And what we found, this is a Globe and Mail article that is reporting on Dr. Reyna's Nature Aging paper, but some of the things that we expected to see here, clearly you could see that the first column, the kind of burgundy one, is the pre-COVID. The kind of greenish one is at the beginning of COVID, and the more salmon-colored one is at the exit, at the 1-year point. And here you could see there's a big increase in the prevalence of depression from pre-COVID to the beginning of COVID. And again, there's a bit of an increase for some groups, but not quite so high in terms of between the spring and the end of year 1 for the pandemic. But what we found were things that we thought we would find in terms of living alone was important. There was a higher prevalence of depression, and females had a higher prevalence of depression than males. But one of the kind of interesting things was when we look at income, so total household income. Clearly the prevalence of depression is highest for the people that had the lowest level of income, but you can also see the impact from pre-pandemic to pandemic was much greater for the people that had higher levels of income. But one of the other things that came from this article is the strong association with pre-pandemic loneliness and depression. And so we dug a little bit deeper into this in our loneliness study. And again, this is a figure that's looking at the predicted probability of loneliness. It's adjusted for all sorts of other factors. And what we see here is, again, the black squares are the pre-pandemic, the red circles are at the end of the first year, and we could see that there is a big increase in terms of loneliness for all groups. But it tends to be a bigger step, like we saw in depression, for those with high income. But one of the kind of interesting things here is if we actually look, it seems that the age effect, which again, we found the highest levels of loneliness in our youngest age group, but you could see the association with age is much stronger in the low income group than in the high income group. And again, having these large sample sizes allows you to sort some of these things out. So the last thing I'm going to present is looking at frailty and healthcare access challenges. And one of the things we were interested in doing, a lot of the public health directives and as well, even thinking about getting vaccinations, it was all age-based. But we were kind of interested in looking at frailty because we know that even in older adults, it's a very heterogeneous group. So we wanted to take a look at that. And here we used the frailty index as described earlier, and we looked at people who reported having challenges with access to health care. So specifically, I'm just presenting the primary care, specialist care, diagnostic tests and screening. But again, we were able to look at pre-pandemic levels of frailty and the other variables that we adjusted for, and then looked at what they reported in terms of access challenges. And what was kind of interesting is that we found overall that people with higher levels of frailty had more reported challenges with access to health care, which in ways make sense because you would think that there's a higher need for health care as well. But when we broke this out then by age, we found that the oldest age group actually had the least impact in terms of frailty. So here we looked at frailty quartile, so 4 would be the people with the highest levels of frailty. And you could see the younger age groups with the highest level of frailty were the ones that were actually reporting the most challenges in terms of access. And in primary care, there was a clear divergence between the oldest and the other 3 age groups, but you could really see in terms of specialist care and as well diagnostic tests and screening tests that there's really this difference in this youngest age group. So here we're seeing that age may, in terms of level of frailty, actually was associated with getting less, having more challenges with access to health care. And this was after adjusting for all sorts of other factors. So I want to just end with this advertisement slide, because I have to, because Parminder's here. But essentially, I really think data sets like the CLSA are going to be critically important in terms of understanding COVID now, tracking things as we move forward, because as we've been talking about, it's not just a thing that where it's going to happen here and we're just going to move on. These are things that we need to be able to track over time and for the long term. And having data like the CLSA are critically important in being able to do this. So we have our questionnaire survey that I described today. We also have a seroprevalence study. And there are, the data will be available to all researchers. So if you're thinking about projects and thinking about better understanding, things that we can use for knowledge translation, the next date of the data access application deadline is September 14th. So I encourage you all to think about things that we can do to inform our way forward.
Thank you very much, Lauren. I think you really highlighted for us all of those sort of intersectional influences that impact people's health and healthcare access. So that was really a great talk. Last but not least, it's my pleasure to introduce Dr. Jennifer Walker. She's a Haudenosaunee member of the Six Nations of the Grand River with a PhD in Community Health Sciences, Epidemiology from the University of Calgary. She's an associate professor at McMaster University in the Department of Health Research Methods, Evidence, and Impact, and the research hub lead of the Indigenous Health Learning Lodge. Dr. Walker's work focuses largely on Indigenous community-engaged health research, using large health service databases through her work as a core scientist and Indigenous health lead at the Institute for Clinical and Evaluative Sciences in Ontario, and through the Health Data Research Network in Canada. I could go on about Dr. Walker's wonderful accolades, but it's just a privilege to have you here. Thanks.
Thank you.
I should always keep in mind that you're going to read whatever I send you. It doesn't need to be that long. Sorry. It's my privilege to be here and talking to you and thinking through these important issues. I'm really glad and grateful that there's space for us to be talking about Indigenous communities' older adults' experiences through COVID-19 so far, and really Indigenous communities and how communities have responded. So, just getting used to things here. So I want to start just by grounding ourselves a little bit in the sort of relationship between colonization and infectious diseases, the experiences that people are drawing on and communities are drawing on when they're contemplating the threat and the experience of an emerging pandemic. So there's a few images here that aren't really showing up in this bright room all that well, but the image, the furthest image over there is an image of a Hudson's Bay blanket. And these images just evoke, a lot of conversation about the fur trade, evoke a lot of conversation about how the fur trade and the sort of expansion of settler society across Canada also resulted in the expansion of infectious disease threats across Canada as well. And so, I know there's controversy about whether Hudson's Bay blankets spread disease at the same time as Hudson's Bay Company providing vaccinations and infection control. But that's like a good example of sort of this duality and this sort of like, thinking that maybe the health system and many colonial and settler approaches to infectious diseases, we caused it, but we're helping. This sort of unburdening of oneself because maybe the intentions are good. And so this is the sort of history that people are drawing on when they're remembering, and they're remembering stories that have come from their own ancestors about the experiences with infectious diseases. And, in some communities, 2/3 of people dying. I also have an image there of the dormitory in a residential school, and just the impacts of tuberculosis and the sort of conditions that have been described as almost being primed for TB transmission in residential schools. And then finally, this very blurry image of 30 body bags that were sent to a Manitoba First Nation community that was being hit hard by H1N1 in 2009. So these are the stories we hear. So as soon as COVID-19 starts to hit, the kind of anxiety that happens from First Nation communities about how the relationships of the past are going to impact the plans for addressing a pandemic. And when I hadn't really I hadn't really done work in infectious diseases. I'm an epidemiologist, but mostly do health services research and research, dementia, diabetes. And when COVID hit and people were reaching out to me and they were saying, last time they sent us body bags, I thought everybody was sent body bags. It was a community in Manitoba. But the narrative, so, I think about that sort of like, how do the media stories impact, and should the media stories impact? They do impact, right? So that's the feeling that one has about the response from a past pandemic that carries forward to current pandemics and future pandemics. So I just wanted to ground us here because I think we can't talk about COVID-19 without this context. And colonization is the backdrop for the relationships with Indigenous populations and leadership. So when COVID-19 started to emerge, we really knew that there were high risks. There was both risk of increased possibility of transmission because of the many of the other things that are realities because of colonization, the lack of clean drinking water and cleaning water, washing water, household crowding, both in cities and First Nation communities, Métis families, and having intergenerational households. So in a lot of cases, older people are living with family members, either full-time or just because family members come and go, and the concept of a household is different in some communities. So when we were talking about a bubble or sticking within your household, that means something different in many First Nation communities. So people are like, well, yeah, we're staying within our household, but it's sort of like sometimes the teenage kids sleep at their grandparents' house, and sometimes they're sleeping here, and sometimes they're at their friends' houses. And there's a lot more interaction that was happening, which caused challenges when we went to model things based on mainstream data. There was also an increased risk of severe outcomes because of higher rates of underlying conditions, and I'm going to show you some of that. I'm definitely going to knock this water over, so I'm going to put it down just a second. I keep touching it. I'm like, I can just picture it hitting someone on the other side of this. And then also a baseline level of less access to healthcare services, resources, both because of jurisdictional challenges. So, we talk about home care and long-term care and things like that. Because of the federal, provincial, and banned jurisdictions, there's actually different health systems that interact and sometimes leave big, big gaps. Also because of geography and because of racism. There's just no getting around the fact that there's racism embedded systemically in our healthcare systems, and we've heard lots of stories. We know lots of stories. We have lots of data about that. So before this report was several years in the making and was released in November of 2019. Okay, so this is a report we did with Chiefs of Ontario. It was called the Ontario First Nations Aging Study. And so remember when November 2019 was, right? So we released the report and it was widely shared in March of 2020, it was sort of in these days before things really started to, it might have been like February 28th or something, but it was at the Chiefs of Ontario Health Forum. So just in time, we had this information that talked about the baseline frailty levels at different ages in First Nations communities in Ontario. So we used data from the Ontario First Nations Regional Health Survey for this graph over here, and I'll just walk you through it quickly. So what we saw was that, it's really hard to see, but there's a little star there and a little star there, and that's based on previous published data about the level of frailty for that age group in the general population. when we did a frailty index using the First Nations data, people living on reserve, the age-specific data are these numbers up here. So the 75-plus-year-old level of frailty in the general population looks a lot more like a population that's 25 to 30 years younger in the First Nations population. So the level of frailty and the complexity of health challenges happens at younger ages for First Nations populations. We used this data, the Chiefs of Ontario were able to use this data to advocate for having vaccines available for all First Nations adults age 18 plus when we were still focused on older adults in the general population. So the data was impactful because it was in the hands of First Nations leadership to be able to advocate for the policies that they needed. I'm also aiming to have strengths and positive things in the messaging. And I just want to say that most of this study, we also did qualitative work, was very positive about the aging experience. And we saw this really remarkable contradiction between this sort of like high levels of frailty and in those very same people, high levels of reported well-being. So people don't feel frail when they score high on a frailty index. It's not part of many people's identities to be frail, right? So it was an important finding. It's not really part of the message today, but I want to say it because, it's important. We also use the data from ICES, which is where all the health system data for Ontario sits. So if you go to the hospital or a physician, there's records kept, and those are linked together. So we used those with Chiefs of Ontario and identified the First Nations people in the data. And in this case, we can look at both on and off reserve. And this is multi-morbidity. So this is the number of people with 2 or more chronic conditions. And so you can see fairly high levels of multi-morbidity across age groups, but both on and off reserve, and actually higher off reserve. And partly that's because people have to move out of their communities if they have multiple chronic conditions, because it's really hard to get treatment for multiple chronic conditions if you're living in a First Nation community. But I just wanted to highlight it because, it's not just remote communities, people living far away that are having these challenges. It's people living in Hamilton, it's people living in Toronto, it's people living in Sudbury. And these are the First Nation communities. This map is hard to see right now, but you can look it up. But the First Nation communities spread. And I just want to highlight for you that there are a lot of Northern First Nations communities. And when we look at the spread of First Nations people in Ontario, about half of First Nations people live in Northern Ontario, and half of First Nations people live in Southern Ontario. So one of the most important things in the response to COVID-19 is Indigenous self-determination and sovereignty. And so that's, I'll just point to the United Nations Declaration on the Rights of Indigenous Peoples, which has just become an act in Canada as well. So it's fully adopted. But really this importance of self-determination. So when we're thinking about responses to pandemics, we have to also understand sovereignty and self-determination. And First Nations enacted sovereignty quite effectively at the beginning of the pandemic. These are images of some of the border controls that were in place to keep people from coming in and out of the communities. Again, just like we heard before, these things were really effective at stopping COVID-19 from entering communities at the same time as being really hard for the people living there. Really hard for the people living there. They tried to get food to people and medications to people, even though they weren't allowing people to leave and come back. But it was really hard. And there were people, really frustrated and reporting challenges. But this was some of the decisions that were made early on. And people were coming to me as a First Nations epidemiologist and saying, can you model for us what will happen? What will happen if COVID gets into our community? How long should we keep these borders up? And, you know, you can't just do that with models. And the models were like very doomsday at that point. We didn't really understand a lot. And they looked like, oh my gosh, if you get one person, it's over. You know, we really have to be careful about the way we communicate these things and the fear that can come, but also, you know, giving and supporting First Nations leadership in being able to make those decisions was really, really critical. And this is just a depiction of that we need to have First Nations governing First Nations data, but also supporting First Nations use of data for governance. It's really important that the decisions are made by Indigenous nations for Indigenous nations. So what we did at ICS was we got information to decision makers quickly. By May, I'd say by May of 2020, we were having weekly COVID testing reports out to Chiefs of Ontario, Métis Nation of Ontario, Grand Council Treaty 3, several individual First Nations, including Six Nations. We were also providing regular reports for, and these are still ongoing, like to Indigenous health service provider organizations. Now we do it every 2 weeks, sometimes every month, because the data's not as good. We all know the testing data is not as good because people aren't getting tested. But what I wanted to show here is look at when the cases started to rise. So all through 2020, it was almost no cases in First Nations populations. The cases started to rise in 2021, but that's because of those really strict sovereignty measures, I think, that came into place. I touched on this a little bit, just about trust and vaccination, but you know, I just want to harken back to that experience with colonization, really tied in with the vaccines. So there's still people who don't trust the vaccine, of course, but there's also people who have vaccine regret. I'm hearing that a lot about just having been herded into and required to get a vaccine and not feeling comfortable about that in retrospect. There's healing to be done, but also because, you know, when the narrative is the government will send body bags if there's a pandemic, then if First Nations are the first to get the vaccine, how is that going to feel, right? It feels like people still say First Nations people were guinea pigs in this process because they were the first, when really the intention was to protect, right? So this the trust building that needs to happen in preparation for future threats and pandemics. Just touching on this idea of a pandemic pylon where there's already a base level of addictions, mental health challenges in older Indigenous adults, in Indigenous communities in general, and just the worsening of that. We tried to continue some of our work with First Nations elders who guide us in our dementia research. And in about January of 2021, they said, that's enough. Like, we have kids dying every week in our communities from opioid overdose and from suicide. And we're not going to talk about dementia research right now. We're going to prioritize that, and we need to prioritize figuring out how to fulfill our role as elders in our communities so that we can support our kids. And so we stopped, obviously, and we tried to find ways of supporting them in their roles as elders when they couldn't sit with the kids, they couldn't be with people the way they were usually with people. It was hard. It was really hard for older Indigenous people to fulfill their roles. And this report came out in December 2020 that I'll highlight for you, and it was really a compilation of stories and experiences. And I think it is stories of strength and resilience, but I want to point out that resilience, Indigenous resilience, shouldn't be misinterpreted, and it shouldn't be mined. The reason Indigenous people are resilient is because of all that crap from the past and present to do with colonization and racism. So we don't want to say, we don't want to glamorize this resilience and say, oh, we need to learn from this resilience. It's sort of, I heard an elder once tell me that if someone's stepping on your foot and keeps apologizing for it and telling you how strong you are while they're stepping on your foot, then you're not going to accept anything until they stop stepping on your foot, right? So that's the experience, is that we need to give space and give space for that self-determination and sovereignty. So I just want to highlight the lessons. I would say is that sovereignty is foundational, relationships are key. We have to honor Indigenous knowledges and strengthen the path to well-being. We need to have that strong, healthy society that is hard to have with the oppression that people feel and the systemic racism that exists. But where relationships are strong, information and support can flow more easily, like getting data to the Chiefs of Ontario and the Métis Nation of Ontario quickly. I've heard stories from communities that are like, we worked really well with our public health unit. Others, we worked really poorly with our public health unit. Some, we were able to support our elders. Some, we were told not to even reach out to them anymore because we couldn't bring them together. So we need to know what to do for next time. Nyawa, thank you very much. I appreciate this opportunity.
Thank you so much, Jennifer. I always appreciate learning from you and thinking about the importance of context, thinking about thinking about past impacts that influence what's happening today in the health system, and how important it is that we really listen to our communities in thinking forward about how we learn from what's happened in the past, more recent past, and what currently exists. So I'd invite all of the speakers from this morning to come on up. We have a few minutes for a panel discussion amongst all six. And look forward to some questions from the audience. And I think there will be a roaming microphone again. Oh, perfect, Casey. I know the panelists have given us a lot to think about, so I just would invite people to ask questions of any of our presenters today. Some of the things, maybe I'll start with a question, and I'm going to start with you, Jennifer. I know you really talked about the powerful influence of using data to inform policy, and I think about the data that's been presented this morning. So I guess maybe asking for your reflections on what we can learn from that about using data and community context to influence policy.
Sure. Yeah, I think that it is a good example of how data, was used in one small way, but with big impact, But I think part of that is the closeness with the First Nations leadership and policy and decision makers. They influenced the First Nations aging study to answer the questions they didn't even know and without even knowing what they were going to need it for. But they influenced the project very closely. So I think somehow it's that close connection, so you don't have to hop 5 steps to the policy and decision makers. Yeah, so I think it's somehow having that real integration into the design of research, the questions that are asked. But we do have a big gap for aging, Indigenous aging data. The CLSA has a gap. The regional health survey that we used has a gap because older people are not, there are not a lot of older people. There's not a lot you can do with the data, to be honest, because they didn't oversample in that population. So there's a gap, but I think that closeness with policymakers, I think, is the key.
Thank you very much. Oh, we have questions in the audience.
Thank you. I was fascinating to hear that, Jennifer, you said people with frailty still had a high quality of life. And if I think about the presentation of the plenary session today, there's lots of focus about frailty is bad. But what is different to do people report a low quality of life and Okay, I'll try to say it really loud. Oh.
There it is.
Yeah.
I was curious to know that Jennifer reported why there was a high prevalence of frailty in older adults in Indigenous communities, but they still had reported a good quality of life. And I was curious to know from all the frailty work that Dr. Bean and Boshab have done, have you ever looked at it, and why would it be different, assuming that frailty comes with multimorbidity and morbidity rates and mortality rates, and why is it different?
So we did an analysis with one of my collaborators, Suzanne Levely, who's a nurse, PhD researcher at University of Massachusetts, Boston, where she looked actually in what are Boston Housing Authority facilities, which are generally serving the underrepresented individuals, lower income, a lot of the different minorities within the greater Boston area. And what you saw in comparison to the other population-based studies at the time is that functionally, which really was their frailty measure, as they pointed out, they were much worse off. But when you actually looked at their attitudes and their conception of themselves, it was actually much stronger, relatively speaking. And I think that really speaks to their lived experience, as was pointed out by Dr. Walker, in terms of the notion that this is the way they have to get by, this is their reality, and so that's part of what sustains them. And it's kind of woven into who they are differently than people who grew up in more privileged settings. Not saying that one is better than the other, but it is the same sort of phenomenon. I was struck by that information.
There's another question just back.
Thank you. I had a question for Dr. Sweetman. I know you mentioned home care a couple times in your presentation. You can stop me if I'm wrong, but I think your projections of the number of PSWs were based only on the residential care sector.
Yes.
Yeah, was that right? So, and of course, you know that, I mean, the home care's had trouble, in recent years keeping service levels, steady, and it's, I'm just wondering, I know your talk was already a little bit, dire as it was, but, how much worse is it when you think about home care? And of course, we neglect one sector, the excess care needs to simply get, shifted over to another sector. Is it even, twice as bad or 50% worse if we're trying to account what the potential gap is in the labor force we're taking into home care and some of the other sectors that employ PSWs?
Yeah, so what I was presenting on was purely for long-term care. Once you include hospitals and home care and other places that use PSWs, the numbers increase dramatically. I haven't actually calculated them for home care yet, but that's on the to-do list. But it clearly, it's an order of magnitude larger. And again, like you saw with Ontario, if there's a policy change, the policy change can have massive ramifications. So if the governments make any decisions to increase home care in the near future, that could, again, dramatically increase the number of PSWs and RPNs that we need in Ontario.
Not seeing other questions from,
Thanks to everybody for great talks. And I'm thinking about when Marla and Jonathan were talking earlier about this connection between frailty and mobility and cognition. And you talked a little bit about how that impacts your ability to go out into the world and do the things you want to do, which might then further worsen your frailty and your cognition, and like that sort of impoverished environment situation where people, the less they interact, the less they socialize, and the more isolated they are, the worse they are off. And then while Arthur was talking about these ways we need to, persuade policymakers, like how can, this is an impossible question probably, but I mean, taking all those three things into account, this, the cognitive and the physical link, and then what happens when people are doing poorly and then they are not able to socialize and they don't go out and they don't cross the road anymore and it gets worse. I mean, can you envision a way forward to convince policymakers that we need to sort of improve all those three things at once and have measurable outcomes that can really persuade people to improve the environment and sort of fix those other two elements at the same time.
So maybe I can comment. I'm going to try to give a positive spin that maybe wraps a lot of this together in some ways. Is that there was a slide that I show quite often talking about quality in healthcare. And the slide actually highlights what's called the South Central Foundation, which is in southern Alaska. And it's actually was a healthcare system that in the US is called the Indian Health Service, which was notoriously underfunded. And what the indigenous people in that area did was they said, we're getting X amount of dollars for our healthcare system. Let us take the money and let us redesign the healthcare system around the needs and values of the people it serves. And over the course of time, what they did was they actually developed the only healthcare system in our country, to my knowledge, that's won what's called the Malcolm Baldrige Award for quality in healthcare. They've won it twice. And so they actually now are an example for innovating within the VA healthcare system at a national level and across the country because of the way they focus. And it ends up being very much focused on the same sort of values about patient-centered care, about how do you redesign systems, how do you support the health providers in ways that they can best support their patients, and really address the values and needs of the population that they're serving. And so I think there's a lesson there, and it's something that sort of builds on a lot of the principles that were presented this morning.
So I'm just going to build on that positive spin there and challenge the panelists as a whole to think about, like, it's really a topic near and dear to my heart for those of you who know me, in terms of how do we partner with and learn from those lived experiences of the older adults who are impacted, thinking about how we, better respond to infectious disease threats in the future. How do we really listen to those perspectives to design the system that we all want to live in? Anyone want to take that up?
Like an easy one. I'll go first, so all the good ideas aren't taken. No, I think I'll make two comments. One is that we need to do a better job matching the type of services and care that are needed in different sectors with the type of care we can actually provide. We have an awful habit of training physicians and nurses and PSWs and designing systems of care provision that are one size fits all. And the type of care that's needed in acute care settings and in home care and in congregate settings, the type of care is extremely different, right? And I'll use the example of acute care hospitals, and this is not meant to be a negative statement to my colleagues who work in acute care hospitals, but the type of care that's required is often very transactional. Our goal is to get you better for this one thing you're here for and send you out of here. In long-term care and congregate settings, the care is all too often transactional right now, and it needs to be transformational. We need to have people that are working in those spaces that have a different mindset. Your mindset needs to be, we are providing care for you, we are not doing things to you. And so there's a big cultural shift that I think has to happen, and I'll get back to it again right at the education level. For entry-level trainees that come into this type of work, their mindset has to be in the right place. The other quick thing I'll say, the solutions don't have to be complicated, and they don't have to involve a lot of money and resource a lot of time. And the example I give everyone is when I go in and do rounds in my long-term care home, and I'm caring for upwards of 60 people there. The day that Dr. Oliver goes to visit, right, I'm there for 3 or 4 hours. I see people. We're dealing with challenges and fires and medical issues. And when I leave, I don't know if people that I've seen are actually feeling a lot better about themselves, right? It's a medical model that I bring. If I go on a day when somebody brings a dog in to walk around and say hi to those 60 people, all of a sudden nobody's got dementia anymore. I mean, people are getting up and they're moving and they're smiling and there's joy and there's meaning and there's purpose, right? It's amazing what, just as one simple example, what pets and babies will do to the day and the life of people that are suffering with a lot of these complex conditions we're talking about. Bring a baby in. The day changes. Oh, sorry.
I love that, pets and babies. I just wanted to add in terms of how we engage. I think there's a lot of push towards engaging patient partners, and I think it's fabulous. But I think we need to engage people, the right people. So in terms of informing models for post-infectious disease care, how we can do better, we need to go out and talk to older adults that have been hospitalized with infection, that have gone through the transition to home, and then ask them, what are you missing? And so, that's something we've done in our cohort study, and we're trying to compile all of that because it's incredible. People have left the hospital and have had zero support and don't have the financial resources to pay for private services. And so I think we have to really think very carefully about who we consult with, and we've got to get as close as we can to those people that have actually just gone through it. And we need to ask them what worked well and what were you missing, and work with those people directly.
Maybe I could add one more thing. There are a couple of reasons to be optimistic about the future. One is the cohort that's aging is the baby boom cohort. And they have been very successful at making society work for them. The baby boom cohort has been very successful and very demanding. And I think that success and that demandingness is going to continue. And the other thing is the baby boom cohort is getting older. It's the same thing, slightly different angle. It turns out that if you're thinking about something like home care, which you brought up earlier, one of the main costs of home care is, of course, the travel time of nurses between homes, or PSWs between homes. And as you have the density of older people increases, then home care becomes far more affordable, right? Because travel time is reduced. So if we can think of ways to reduce those transaction costs, and I think the aging cohort is going to do that for us, that solves a problem. At least it solves the problems in urban areas. It solves some problems in urban areas. It doesn't solve the problems in rural areas. But I think it makes home care more affordable. We also need to change the discussion in some sense. So think about what happened in the most recent federal budget. There was a big, it wasn't, oddly, it didn't hit the headlines as much as I thought it should be, but the biggest expenditure, one of the biggest expenditure items was a give to people over age 65. But what did they do? They increased the OAS, old age security, which mostly targets, it doesn't target very high income people, and it doesn't target very low income people. It hits middle and upper middle income people primarily. Right? They could have put that money into the guaranteed income supplement and targeted low income people, but they chose not to. And they didn't put the money into home care, which they could have, or into pharmacare, which they could have. Right? So right now, what the people seem to want is upper middle income dollars into wallets for people to do with as they wish. And I actually believe democracy works. The reason the government did that is because that's what people want in society. So if we want better home care, what we need is for society to tell people, to tell politicians in particular, that we want better home care. And I think that's coming because the baby boomers are getting to the age where they're going to want home care and they're very demanding. So I think the future is going to see some improvement just based on that.
Well, thanks for that positive note to end on. I think we have lots of reasons to be optimistic about the future, and with all of these minds here on the stage and all of the minds that are part of MIRA and Global Nexus to come together and to work with our communities to really come up with some meaningful solutions in the path forward. Thanks for joining us today. Thank you all.